I'll be talking about IVUS and OCT in coronary artery disease. So it was the ultimate trial that compared angiography guided versus IVUS guided PCI. And we can see here that the IVUS guided PCI, the target vessel failure was much less as compared to the angiography guided PCI. And in the IVUS guidance, they again divided it into suboptimal and optimal PCI depending upon the stent expansion, the landing zone, or any edge dissection. So in optimal PCI, there was again a statistically significant difference from the suboptimal PCI. So in the Lumen trial, the minimum stent area rather than the angiography guidance was used, but there wasn't much difference, but it led to more stenting. So if the distal to proximal MLA was less than 4 and if there was an edge dissection, so it led to stenting at the distal edge. So the Renovate complex PCI trial in which there was an angiography guided versus the intravascular guided, the death, target vessel related myocardial infarction, both were less, in which intravascular imaging was used to guide the PCI. So in the October trial, again the OCT guided PCI had a much lower MACE as compared to the angiography guided. In STEMI patients, again, there was 15% reduction in stent implantation with OCT guidance. So the indications in coronary interventions being that in intermediate stenosis of the left main, IVUS is reasonable to help define the lesion severity. And in patients undergoing stent implantation, particularly in cases of left main or complex coronary stenting to reduce ischemic events, it's again 2A. And in patients undergoing stenting, OCT is reasonable alternative to IVUS for procedural guidance, again 2A. And in patients who have a stent failure, so imaging is a 2A indication. And in patients with ACS undergoing complex stenting procedures like left main or multivessel, intracoronary imaging or OCT is recommended as a class 1 indication. And this is back in 2021 ACC guidelines. So these are this is the summary of the indications in which class 1 being an ACS scenario with left main or complex PCI. So the sizing variability between the different modalities, the OCT is the most accurate, the IVUS slightly overestimates, QCA underestimates, and the visual estimate is there is too much inter-observer variability in the visual estimation. So OCT as compared to IVUS, the penetration power of the OCT is less as compared to IVUS. Other than that, the OCT gives a very good resolution and nicer pictures. So this is an IVUS image showing a normal vessel with intima, media, and adventitia. So this is again another picture with plaque present under the intima. So we can use coronary imaging for PCI planning and optimization. So planning, we need to identify the landing zone, the stent diameter, the stent length, and the lesion preparation according to the lesion morphology. And optimization like stent expansion, apposition, edge dissection, or an edge plaque shift. So landing zone selection has to be less than 50% plaque wherever your stenting is landing in the distal or the proximal portion. This calculation is done by the machine itself, so we do not need to remember this formula. So this is an image showing where the stent is in a place where the plaque burden is more. So this is not an optimal location for stent placement. However, on the right side, you can see that the plaque burden is 36% and you can place the edge of the stent in this area. So you can use the distal reference lumen diameter for the stent size or distal EEM, and do not use the EEM at the lesion because of positive remodeling. You can oversize the stent. So here you can see angiographically as well as IVUS images. The distal reference is around 3 millimeters. At the lesion, it is more, and the proximal reference is around 5. So you can see finally the lumen areas are quite adequate after the stenting. So stent length can only be determined if you have the auto pullback feature available. Otherwise, by a manual pullback, you can't sort of determine the length of the stent. So there are different types of plaque morphology. So they can be a soft plaque, a mixed plaque, and a calcified plaque. And heavy calcium is defined as a greater than 270 degrees, length of greater than 5, and thickness of greater than 0.5 millimeter. So you would need some kind of plaque modification like rotation atherectomy or any other procedure to have optimal results. So these are again various types of plaque. So how to differentiate between a fibrotic and a calcific plaque? So there is no signal dropout, although the fibrotic tissue is also very echogenic, just like the calcium, but there is no signal dropout. So dense calcium will cause a signal dropout on the IVUS image. So here again are pictures of calcified plaque, a 90-degree arc. There's deep and superficial calcium in the next image. Then there is a 180-degree arc, and then there is a 270-degree arc. So you can see that there is a signal dropout behind the calcium. So here in the first image, you can see the calcified nodule. There's another calcified plaque which is more than 270 degrees, and after using the IVL, you can see that there are fractures in the calcium. So post-stent, the well-expanded stent would be greater than 90% of the distal reference. Or you can use absolute values like left main of greater than 8 or non-left main of greater than 5.5 millimeter square area. So again, in longer stents, the proximal MSA should be 90% of the proximal reference, and the distal stent should be from the distal reference. Now, what to do if there is an edge dissection you see on IVUS? So you will have to place another stent if the dissection either extends to the media, is longer than 3 millimeter, or is greater than 60 degrees. So for a greater than 50% plaque burden at the edge, an undersized balloon inflation or leave as such, no further stenting is required. So for malapposition, you can use a more aggressive post-dilatation. So again, the same thing, that if you have a dissection that is larger than 3 millimeter, greater than 60 degrees, going into the media, you need to stent that edge dissection. And the post-dilatation in case of under expansion should be with an NC balloon measured from the distal external elastic membrane and inflate at high pressures. So this is the final slide, and this is showing suboptimal versus an optimal result after a PCI. So in the left images, you can see that the stent is underexpanded and there is an edge dissection. And on the right images, you can see that the stent is placed in a place with less plaque burden, the expansion is satisfactory, and there is no dissection. Thank you very much.